But basically what I'm going to talk about is the use of botulinum toxin in Parkinsonian conditions. And this has significant application specifically in PSP because there's a number of symptoms associated with PSP that can be amenable to treatment with botulinum toxin. So where we don't have a lot of pharmacologic treatments for the symptoms of PSP, there are certain things that can respond and benefit from Botox or botulinum toxin. And so the first thing I wanted to do is explain what botulinum toxin is, because for most people you're going to be thinking about it from the standpoint of the cosmetic usage of Botox. That's how we sort of learn about the concept of Botox. But Botox has been used in medical conditions for over 30 years, almost 40 years now, and started with a lot of issues related to the eyes and eye movements and eye blinking or eye closure. And what botulinum, oh, here we go. Yeah, awesome. Did you put the USB in there? Yep. Awesome. All right. So if I start talking, so the role of botulinum in Parkinsonism. And so I wanted to explain what botulinum toxin is. And what it is it's a protein. And proteins are compounds that have very specific jobs or functions in the human body or in an organic body. And the protein botulinum toxin is actually derived from a bacteria called Clostridium botulinum. But it's been isolated in terms of the specific protein and then formulated with different brands. So there are different companies that make different strands or strains of botulinum toxin, all of which are pretty effective in treating various conditions. And this, what botulinum toxin does is it is injected into muscles, and it's taken up by the nerve ending in the muscle, and it prevents the release of acetylcholine. That's a neurotransmitter chemical, these little red dots, that's in the nerve ending. So this is the nerve ending, and this is the muscle. So the nerve ending talks to the muscle. When your brain says to move, it sends a signal down, and eventually that chemical comes down out of the nerve ending, binds to the muscle, and tells the muscle to contract. So the toxin is injected into this area, and it's the protein, and it's taken up by that nerve ending. It blocks the release of that chemical. So the effect of botulinum toxin is to relax muscles. So we're dealing with conditions of dystonia, rigidity, involuntary movements. There is some utility to being able to relax muscles. Now, what I want to always emphasize to people is it doesn't provide strength, it doesn't give you function. Its goal is to take away involuntary contraction by blocking that connection, making the muscle more relaxed. Okay. It's measured in units and essentially made into a solution, which can be drawn up in a syringe and injected directly into the target muscles. Okay. So unlike pharmaceuticals, which come in the pill form, go into your GI tract, get into your bloodstream, and really go everywhere in your body, this is a treatment that's selective in a sense that you inject this protein in the target of the therapy. So side effect wise, it's actually pretty well tolerated because it isn't something that's going through the whole system. There are microscopic or small amounts of botulinum toxin that can spread to other areas of the body, but they generally don't have any sort of effect at that level. But you do need to keep in mind the risks of any treatment, and because this is a protein that weakens or relaxes muscle, if the dose is too high or if the patient is sensitive to the toxin, you can get too much relaxation, which is weakness. So that's one of the potential side effects is that you overly or excessively weaken the muscle you inject. If you're injecting in areas of the body like the neck or the face that are close to muscles of swallowing, there is the potential to impact swallowing negatively. So we have to keep that in mind, especially in a PSP population. Certainly the possibility with any injection is that you might have a reaction at the site of the injection, a possible allergic reaction, the potential for bleeding or infection. These are extraordinarily low risk issues because it's a very superficial injection for the most part. Most of the time we're just injecting right under the skin, so these are issues that we can control. So risks are actually very low. These adverse responses are very uncommon. This is just examples of the various products that exist. and they come in vials. Sometimes you have to add saline, sometimes they already come in solution, and then we draw it up, dose it as depending on the condition and the target, and inject it. So what kinds of issues do we treat in Parkinsonian conditions with botulinum toxin? This is sort of a summary of 3 things I do often in the clinic to help folks. One is a general category, which I'll go into more detail, which is dystonia. Dystonia is involuntary contraction of muscles that create some twisting or turning posture that's unintentional. The other condition we treat is something called blepharospasm, and that refers to the involuntary closure of the eyes, or another sort of related element to that, which is something called eyelid opening apraxia, and I'm going to explain all this in the next slides. And then the third thing we use botulinum toxin for very commonly that can be very helpful is for excessive salivation or drooling. So yeah, I sort of want to make the point with folks who have conditions that have been told there's nothing we can do to treat this, at least in the doctor's office. There's certainly a lot we can do in the therapist's office. But there are some therapies that could be helpful depending on what the issues are. So dystonia is a descriptive term that describes the symptom of involuntary twisting or turning that results in abnormal postures due to involuntary contracture of muscles. And that can occur anywhere in the body. Dystonias can be an independent medical condition. There are genetic forms of dystonia that can develop in children and adults. But we often see various forms of dystonia in Parkinsonian conditions. So let me give you some examples of what we mean by that. So one form of dystonia is cervical dystonia, referring to the neck. And folks with Parkinsonian conditions can develop involuntary contracture of those muscles, so they develop movement of the head. And one example is anterocollis. That just refers to the direction of movement being anterior or forward. A lot of folks with MSA tend to have a sort of a forward lean and their head is pushed down. And so it can result in that position. A lot of folks with Parkinson's disease and PSP will have sort of tilting, potentially to one side, so the head tilts and maybe goes forward or even sometimes a little bit backwards. These things can occur in the condition themselves, and sometimes they can be side effects of some of the dopaminergic medication that they're taking. So these are just examples of the various positions. So this is head down, head to the side, head back, and then the other one is rotation, so the head turns. Another example of, and so the idea here is that depending on the movement you're seeing, you inject the muscles that are creating that movement, that are overactive. But by relaxing those muscles, you release that pressure of movement in that direction, and the head can come back up or be a little bit more straight. Another example of dystonia is something called focal dystonia. That's just a descriptive term. It refers to a dystonia in a very focal part of the body. And we often see dystonia in the hand or the arm, or dystonia in the foot. So this can create sort of like a fist or the thumb tight in the hand, the foot turning inwards or pushing downwards so that gait can be affected. And in one case series of about 80-some patients, about almost 30% actually of PSP patients had some form of focal dystonia of the limb. And so the treatment in these situations, there's potentially medications like muscle relaxers and things like that can help a little bit with these kinds of problems. But the problem you run into there is that the benefit is not outweighed by the risk most of the time. Because these are pills, because they're sedating, they can cause confusion, they just make you real sleepy. And for something very focal, where the problem is only in one small area of the body, taking something that goes everywhere in the body isn't necessarily ideal. So Botox can be helpful in these focal dystonias where you specify the muscles involved, whether they're finger flexion muscles, wrist flexion muscles, thumb flexion muscles. You target those muscle bellies that do those specific movements, relax them, and allow potentially the hand to open up to have more range of motion. In some cases, because the arm is full of muscle bellies that have all kinds of different functions, in order to target the exact specific muscle belly we'll use what's called EMG. If anybody's had a diagnostic EMG, that's a needle exam. The needle is placed in the muscle, and we can hear muscle activity. So if you activate the specific muscle, you can hear it firing, and then you can inject Botox or botulinum toxin through that same needle and target that muscle. Okay, so another use for botulinum toxin in PSP specifically is going to be with this issue called blepharospasm. So blepharo just refers to the muscles of eye closure, and spasm is, I think, obvious. So what happens in blepharospasm is people have an involuntary contracture of muscles that causes them to forcefully close their eyes. And that can last for minutes to hours. And so that can be very disabling when you basically lose your vision and it's out of your control. And then in some cases that will occur, and then the muscles will relax, but yet the eyes won't open. And that's something we call eyelid opening apraxia, where the eyes are closed, the patient doesn't look like they're really pressing them closed. Their eyelids are down, and then it looks like they're sleeping. Some people will say, yeah, I thought he was sleeping. I said, wake up, wake up. And the patient will say, I'm not sleeping. And it's hard to understand what's going on. But what's happening is something called eyelid opening apraxia, which is basically an inability to just spontaneously open your eyes. So just the act of opening our eyes becomes a challenge. And sometimes that can respond to sensory tricks, where if you just kind of push on the eyebrow or pull on the eyelid, the eyes will open up. But that can be, a difficult thing to be dealing with throughout the day. So what we're able to do with something so focal, with small little muscle bellies, is inject very low doses of botulinum toxin, specifically in the eyelid muscles on the edges and in the circular muscle that goes around the eye. We inject a little bit there. In some cases, we might inject in some other muscles sort of around that area, in both sides of the eyes. And that really helps, actually, quite a bit. Keep the eyes open, they're more relaxed, and they just stay open. And so that can be very effective and improve a disabling symptom. And then the last thing we use toxin for is what's called Sialorrhea, which just means excessive salivation. It's not really an excessive salivation problem. Oftentimes the amount of saliva production is the same as anybody else. The issues are more that because there's a lack of spontaneous automatic swallowing, saliva just pools in the mouth. Right? So we don't realize it, but we're actually swallowing all day long without even thinking about it. And we're producing saliva all day long without even thinking about it. And that's impaired once that automatic swallowing reflex is reduced and the saliva pools in the mouth. And it can start with mild symptoms where you just kind of notice a little bit of excessive pooling. Maybe you just see a little wetness on the pillow that can get to be half the pillow. At night, because you're sleeping, you're laying down, the mouth might be open. But as it gets to be more significant, you start to see issues with drooling, which can be sort of embarrassing or awkward. And that can occur because in addition to the saliva pooling, some of these conditions cause postural changes where you're leaning forward or to the side. And in addition, oftentimes the mouth may even hang open, and so then the saliva comes out. The other problem people experience is their mouth is full of saliva, and that's one of the reasons why they're not talking. Because they're scared the second I start talking, bleh, it comes out. And so it can be a disabling speech issue as well that this can be helpful for. And while we do have medications that help reduce the amount of production of saliva, once again, these are pills, and they go in the body and they go everywhere, including the brain. And their mechanism of action specifically affects that chemical acetylcholine, which is involved in secretion of saliva as well, but also involved in our memory. And it's a chemical in the brain involved in our working memory. So pills that reduce saliva production can certainly impact memory negatively and cause confusion, hallucinations, issues like that. So once again, we have a more focal treatment where we can inject it right into the salivary glands, reduce the overall production of saliva so that the balance is in the favor of the patient not having so much pooling in their mouth. So here's just a picture. Like I said, we target the parotid gland or the submandibular gland. There are multiple salivary glands, and we don't necessarily inject all of them. We aren't injecting enough toxin to eliminate saliva production. It's extraordinarily rare to see issues with dry mouth or no saliva production. So it's a nice balance of just reducing the production of saliva to the point where it's less of a problem. So this just shows the parotid gland is really right under the skin in the cheek. Submandibular gland is just under the jawline. You can often feel that little swelling under your jawline. If you push hard enough on it, you might find a little extra saliva in your mouth. And so just some general things to know about botulinum toxin that I explain when we're going to use it is that it's not an immediate effect. So it's not like getting a steroid injection. It can take a couple of days to even start to work. And really it builds up over several days to the point where you might see the maximum benefit around 1 to 2 weeks. And generally, the toxin only lasts about 3 months. Your body identifies it as a foreign protein and your immune system clears it out of your system eventually. Then the effects will wear off. And so people will experience that phenomenon and they come back with routine, usually every 3-month appointments to have repeat injections. So it is an ongoing treatment. It's not a single one-time thing. And in the case of dystonias specifically, because they're larger muscles and because the movements are complex and complicated, it may take several sessions to really identify the appropriate dose and choice of muscles to inject to get the optimum benefit.